So, ladies and gentlemen, dear colleagues, thank you first for inviting me to this Congress. I think it's a hard work to do this now, for the actual ESC guidelines are only valid till the end of this month. In August 2021, there will be the new ESC guidelines. So I think my task is to make you curious for the new guidelines and to show you something that you can look up in the new guidelines when they are arrived. These are the old guidelines. This is a central figure for the patients with heart failure with reduced ejection fraction. And you see here the stepwise approach with first the ACE inhibitors and the beta blocker. Then when the patient is still symptomatic, the MR antagonist. Then also still symptomatic, change to the ARNI and look for other therapies. So we will see what will be changed in the next guidelines. This is new, a position paper of the heart failure societies of the Canadian, the Indian, the American, the Japanese, and of the Heart Failure Association of the European Society. They tell us here about the signs and symptoms, the laboratory tests, and the objective evidence for cardiogenic pulmonary or systematic congestion. That is not new, but as we had a new form of heart failure in the last guidelines, we now have a fourth class of patients. You see here the HFrEF and you see the HFpEF patients. And as it was introduced in 2016, there is another class between these with the ejection fraction between 41 and 49. At that time, it was called the mid-range ejection fraction. Now they call it the mildly reduced ejection fraction. But this is new. This is the heart failure with improved ejection fraction. And I think that is a good classification, for we have patients that had initially severely reduced ejection fraction, and after therapy, they have a better ejection fraction, and they say it must be better than 40%, better, more than 10 points increase from the baseline ejection fraction. So I think we have now 4 classes to discuss with our patients and perhaps with our therapies. Heart failure is a malign disease. It has a survival rate of about 50% after 5 years, and 1/3 of the patients will live after 10 years. That is a poor survival, poorer than many cancer diseases. And I think this is also our task to look for the patients. For if you look at this paper from Pecker and Mitra, they showed that only less than 1% of the patients have all the guideline-directed medical therapy and this therapy in the right dosage. And this has also shown in the CHAMP registry. And you can see here that about 1/4 of the patients will not get an ACE inhibitor or ARNI, having no contraindications, but they are not treated. And this is 1/4 of the patients. And for the beta blocker, it's 1/3 of the patients. And for the MR antagonists, it's about 2/3 of the patients. That are very high numbers, and that's not good for the patients. It can be shown from meta-analysis of the heart failure studies that more drugs will have a better outcome in survival. Mortality will decrease with the substances given compared to placebo. And this is not only a number, that this means a lifetime for the patients. You see here the numbers from the emphasis heart failure trial with the patients with ACE inhibitors ARB or beta blockers compared to those with additional MR antagonists. And you see here that there is a difference. And for a 55-year-old man, this is about 8 years, 6 to 10 years, 8 years longer life for these patients. And I think we have to work for our patients. And it's not only giving the drugs, it's also starting the drugs. For when you look at the data of the Pioneer HF trial, you can see here, this is the ARNI, and this is the ACE inhibitors, that even at the time of 1 month, there is a significant difference between the groups. So starting early is better for the patients. You can see it here with the changes in the NT-proBNP levels. At 1 week, there is a significant change. And these differences with the clinical benefit in the first weeks of the treatment, you can also see for the empagliflozin and for the dapagliflozin. So it's urgent for the patient to start early with the therapy. And we have to think of those who will benefit most from our treatment. You can see here from the data of the dapagliflozin trial, those patients with prior heart failure hospitalizations. If you have never had a heart failure hospitalization, there is a difference between the groups, between the dapagliflozin and the placebo group. But for those who had a heart failure hospitalization less than 12 months ago, the difference is much higher, so they will profit more from this therapy. But we don't know how to do this. You see here the scheme for the guidelines from 2008. All the substances were given one after another. Then in the 2012, ACE inhibitors and beta blockers were given together. And we don't know what we will hear in 2021. Will they all give together, and how shall we do that? We don't know. But we will see in end of August at the Congress. I think when we talk about the ARNIs, they in the upcoming guidelines will probably allowed to be given not in the follow-up, but early in some patient groups. I look forward to what they define for these patient groups. And if you have to switch from ACE inhibitor to ARNI, I want to remember you that you have to have a pause of at least 36 hours. Let's have a look at the new class of the sodium-dependent glucose transporter 2 inhibitors. They work at the kidney in the tubuli, and they reduce the glucose reabsorption, and with this the patient will lose glucose, sodium and water, and this will help him. And this could be shown in 2 great trials, the Emperor Reduced trial and the DAPA HF trial. All these patients had ejection fractions below 40%, and it was allowed to have depressed renal function, but with a GFR of above 20 for the empagliflozin and above 30 for the dapagliflozin. And the patients had a positive effect from this. They had less hospitalizations and there were fewer deaths. And that's very important, the dapagliflozin was as effective in the patients without type 2 diabetes as it was in those with type 2 diabetes. The Emperor Reduced trial also showed a positive effect for death and recurrent hospitalizations for the substances and the patients treated with empagliflozin. What have we looked for the sodium glucose transporter? We have to see that they will have a volume depletion. And so in all patients, you start with the therapy, you have to adjust the diuretic therapy. You have to know that there may be a diabetic acidosis and there is glucose in the urine. So in the studies, they had more urogenital infections in these patients. We are waiting for the ESC guidelines, but I looked up for you for the other guidelines. The Canadian heart failure guideline was just published in the spring this year, and they start with an initial therapy of ARNI or ACE inhibitor, then beta blocker, then the MR antagonist and the SGLT2 inhibitor, same as all as a standard therapy for these patients with an ejection fraction below 40%. And they put all the other therapies around that. And then I looked for the ACC expert consensus in heart failure, and they have, for those patients with a heart failure with reduced ejection fraction, the ARNI and the beta blockers and the diuretics, and they add the other substances around this. So they differ, and we are waiting for what the ESC will tell us. The ACC has all these substances near to each other with all the contraindications and indications and dosages you have to recommend. I think it's very nice to read this. But there are also two new medications. One is the vericiguat, that is a stimulator of the soluble granular cyclase, and the other is the mucin activator omecamtiv mecarbil. The vericiguat was published in May 2020. It's the Victoria trial, and this Victoria trial could not give us a better outcome for death, but there were fewer rehospitalizations for heart failure in the vericiguat group. So the data is not so that we have to use this in the first line, but it's for those who have repeated hospitalizations. The omecamtiv mecarbil mucin activator, this medication makes that the mucin heads will work better in the patients. You see here, before the drug, there are less of the mucin heads that are working compared to with the drug. So the Galactic trial showed us. It was published in January this year, and it also has no significant data for death, but some data for the hospitalization heart failure events. I found the ACC expert consensus guidelines very good for the comorbidity management, for they told all the comorbidities, and all heart failure patients have up to 10 comorbidities. And you can see here that these may be cardiovascular, these may be systemic, these may be general conditions, and they show where the guidelines are for these comorbidities. And I want to stress on one comorbidity. For the tafamidis was published in 2018 in the Ataract Act trial for patients with transthyretic amyloid cardiomyopathy, and it showed that the mortality of these patients could be reduced with the tafamidis. Survival was much better in those patients after about 2.5 years. And it was not only the death, but also the rehospitalizations. But we have to look that the therapy, it's a very expensive therapy, has to be initiated early. For the survival was better and the hospitalization rates were lower in those with New York Heart Association classes 1 and 2 compared to those with class 3. So we have to think about these disease, and it will be stressed in the guidelines. I told you that we don't know how the FESC will put it in a figure, but Professor Bauer-Sachs from Hanover Medical School made this figure in his paper, and he called it the Fantastic Four. And this means that you have these 4 drugs, the beta blocker and the ARNI, the SGLT2 inhibitor and the MR antagonist, and you have to put all your other therapeutic things around that, meaning looking for the rhythm, looking for even things like left ventricular assist devices or heart transplantation or valvular therapies like mitral edge-to-edge repair. So I think we are waiting for how they will do it. But I want to show you that heart failure therapy is not only taking the diagnosis and prescribing or titrate a medication, but it's also patient education, lifestyle prescription, and psychological and social support, and of life counseling and care, and coordinating the comorbidities. There are only few information about the new guidelines from the Heart Failure Congress some weeks ago, and they told that there will be a simplified treatment algorithm for HFrEF patients based on the 4 major classes, that there will be some recommendations for the treatment of mildly reduced ejection fraction, and that there will be some treatment algorithms for the phenotypes for the patients with a broader QRS complex or the ischemic versus the non-ischemic etiology, for rhythm problems, for the comorbidities, diabetes, iron deficiency, hyperkalemia, for cancer patients, and for amyloidosis or other cardiomyopathies. So I hope I have made you curious about the new guidelines. These are the data for the Congress. It will be only online, but I hope I can see you on the ESC Congress 2022 again. Thank you for your attention, and now I'm ready for the discussion.
I have a question. Thank you very much, Dr. Gerecke, for very informative and latest information of your presentation. I have 2 questions about the treatment for a patient with heart failure with reduced EF. The first is the ARNI and SGLT2 has a priority than diuretics in the patients with low blood pressure, I mean less than 100 millimeter. For example, he's already under loop diuretic and MRA, and then we need to do some ARNI or SGLT2. Should we reduce the dose of the loop diuretic or not? And the second question is, if the patient has an ischemic heart disease and a reduced EF, then how about the role of the statin in these patients? Should we keep the target LDL cholesterol, or we should reduce the dose of statin?
Okay, let me try to answer the first question. I think the blood pressure is often a problem for giving the ARNI, and there are patients that will not tolerate the ARNI for the reduction in blood pressure is more than when you give candesartan or valsartan drug. So we try it in very low doses, and we try to elevate the dose over time. But that is a problem for some patients. With the diuretics, you have only to give the amount of diuretics that you need to keep the patient without congestion. If all the water is out, you can decrease the dosage of the loop diuretics, and most of the people, also those with the severely reduced ejection fraction, will need only small dosages of the torozolid, for example. So you have to try and to look, but I always tell the patients that the diuretics, the torozolid, is not for prolonging their life, but to keep out the water of their bodies. And then if we have to talk about the ischemic patients, there are some data from former years and studies that the statins will not help for those who have heart failure. Heart failure itself cannot be addressed by the statins. But if we know that the patient has severe coronary heart disease with progress over time, then we try to give them the statins. But when they are, I will not address a limit of 45 or 55 milligrams per deciliter LDL cholesterol for these with severely reduced ejection fraction.
Thank you.
And now I have a question here on the screen. I have I've never worked with finerenone. I don't know if this would help. And this is the New York Heart Association 3 patients. I would change the spironolactone to eplerenone. For the eplerenone makes less blood pressure reduction than the spironolactone. I think the beta blocker, I will try to have a good heart rate below 70 for these patients, and I would try to give this. 2 weeks ago, I had patients who were very small, and she had lost weight for about 10 kilos in the last month. I had to stop the SGLT2 inhibitors, for she lost water, and she lost the glucose with this medication. I think we will have our guidelines, but we have to treat every patient with his complete conditions to help him. Are there any more questions?
Yes, sir. Hi, Professor Birgit Gerecke. It's a long time to see you.
Hello, thank you.
Yeah, very happy to see you in very healthy appearance. Yeah. So I recently we have many information concerning about the drug therapy in case of heart failure reduce EF, and they advise to use association many heart failure drugs. For example, RNA and SGLT2 inhibitors. So in case of end-stage renal heart failure, can we combine R9 and SGLT2 inhibitor?
You can combine these drugs?
Yeah, in case of end-stage of renal failure, kidney renal failure.
You have to look whether there is any contraindications. If the if the GRF is below 30, it's hard to do the ANI, and if it's above 20, then you may not give the SGLT2 inhibitors. So they are not allowed at that time. There are data for kidney diseased patients that the SGLT2 inhibitors will improve the renal function over time, but it's not allowed to give them at this time. I think we have to wait for more data.
Okay, thank you.